This season of the Breech Birth podcast will be a little different. I'll be speaking with researchers, midwives, and obstetricians working within the breech birth space, bringing additional perspectives, knowledge, and evidence-based research to you, the listener. I hope you enjoy these conversations. Hi, Ashlee. Welcome to the podcast.
Thanks for having me.
Before we jump into a few questions, could you please share a bit about your background and what you're doing in the breech space?
Yeah, so I'm a privately practicing midwife. I'm currently in the greater sort of Sydney area, and I'm one of a very small number of fortunate midwives who has been attending breech births throughout their whole entire career. So I did my midwifery training at a tertiary hospital in Sydney, and I was the first group of midwives after the term breech trial that they started emphasising on reintroducing breech training with. We had a breech obstetrician, and I ended up working for quite a number of years in a group practice where a lot of breech clients were funneled through. So it kind of just became a natural progression point of that I attended. That was quite a normal sort of thing for me. And then I've had one of my own baby's breech as well. So
amazing. If you feel open to share that story towards the end, please do. So off the top of your head in your practice, how many breech births have you attended?
I actually was thinking about this because I'm not 100% sure exactly how many it's been now, partly because the second twins are your most common sort of breech birth, and there's been those. Thinking more of the like Hilton planned breech, those sorts of things, I'm probably sitting about 30 at the moment.
Great.
So
more than most Australian midwives.
Yeah. Like, you know, I've been a midwife for over 15 years now, so it's certainly not crazy sort of numbers, although in recent times, those numbers are definitely picking up very quickly.
Yeah, great.
Yeah.
So you've mentioned that you've attended twins. Is that something that you're regularly supporting? Have you got women seeking your support, knowing that 50% will potentially have a breech baby?
Yeah, so I'm actually a twin mum of myself. So
Same.
my second twin was my breech baby, and we can talk about that later. It wasn't the most straightforward birth, but I guess, yeah, like coming from having that experience of working in a tertiary hospital, I also have admitting rights in a tertiary facility, a collaborative agreement with a very, very skilled and woman-centered obstetrician who also supports twins. So, yeah, there's probably a handful every year. And then in my time during my training being in the birth unit as well for the period of time there that I spent, I think I attended like somewhere between 10 and 15 twin births just while I was pregnant with my own twins. So I kind of remember those ones a lot more vividly, partly carrying twins yourself in the space going, okay, yep, these are, yeah, and seeing some crazy things.
Helping you know exactly what you did and didn't want for your own experience.
Exactly. Yeah.
Yeah. Great. Yeah. What's the most unusual situation that you've witnessed at a breech birth?
I don't know if I'd have actually anything particularly unusual. The vast majority of the breech births that I've been at have been quite straightforward. The ones that haven't been quite so straightforward are things that we would anticipate. So in terms of maneuvers that are required, sometimes babies needing assistance. The weirdest twin birth though that I've been at one that the twins were born 5 weeks apart from each other.
Wow.
And there was another one that we did, it was when the times changed. So the second twin was born before the first twin, and the computer system really couldn't handle it because it was on the daylight saving shift. So that's probably in terms of like the weirdest thing. So not really specifically breech related there.
The 5 weeks.
Yeah. The first one was born at just over 23 weeks gestation, and the second one was born. Yeah, so
I assume she just stayed in hospital for that time until the next one.
Yeah,
decided to come.
Yeah.
Fascinating. What have you learned the most from witnessing breech birth?
I've spent a lot of time reflecting on Christine Laurier's words about, like, I think particularly as there's been a push to return towards competence around vaginal breech birth, you hear a lot of people say, you know, breech is just a variation of normal, those sorts of things. Christine's very much of the opinion that breech is not a variation of normal, but I think the reason as midwives that we have been attracted to that sort of language is because the idea of saying that it's not normal invites needing a lot of obstetric intervention and therefore can justify, say, having a cesarean. I do have a very healthy respect for breech. I absolutely love doing them. I mean, I don't generally tell my clients in my practice, like sometimes they go, well, what would you do? And I'm like, well, my job's not really to tell you what I would do. I'm here to give you the information. You can make the decisions you want yourself. I did have a client recently going, well, do you have a vaginal breech birth? And I said, well, I'm not really going to answer that specifically, but also given that I've had a breech baby, kind of know what the answer is to that. I've also seen breech births be really, really complicated. And that's a really humbling experience. But I guess it teaches me that women are amazing. Their bodies are amazing and that we are completely capable of doing things most of the time.
Yeah, absolutely. And coming back to that statement around the breech birth is a variation of normal, because I teach breech, I talk about it being a variation of birth, because it's no different to shoulder dystocia, especially when you get a surprise breech. Doesn't necessarily mean that we can't manage it. We just need to be competent and skilled and have that knowledge.
Yeah.
Like we do for a shoulder dystocia, just the same. We need
Yeah.
to know what to do. Do you have any expectations or boundaries when working with women who have a breech baby on board?
I guess when you look at international guidelines for inclusion in breech birth, it's really quite generous. I wouldn't say that there is anything that's particularly untoward. Most of the time it's like suggesting that the baby should be over a kilo, which is not bad. And there is a consensus internationally that some places will say 4 kilos, some places will say 4.5 kilos. So there is a stronger association with poorer outcomes in some of those larger babies. I've seen a mixture of things between some people being quite willing to engage in that kind of process of counselling and screening and those sorts of things, and other people not. You know, if you were to say who is not suitable to have a breech birth, you're talking about babies that are incompatible with vaginal birth. So you're looking at a baby that is essentially not neurologically intact. I don't agree with ultrasounding antenatally to check if the head is flexed, those sorts of things, because any neurologically sound baby should be maintaining a flex position. But yeah, I'm also very much supporting women's decisions, but I have had clients where I go, maybe this isn't the best, most ideal scenario, but I trust that women want the best for them and their baby. And I think that's something that I always have to hold on to, is that women will make the best interest, and no one wants to do anything, the vast majority of the time, in my experience, that is going to risk their or their baby's well-being. And it's just, being honest and open with people about what we can know and the limitations of what we don't know when we're making decisions about things that have not yet unfolded.
Absolutely. Have you encountered any barriers or limitations in your practice in relation to breech birth as a practitioner? And if so, what were these?
I'm kind of moving forward in this space, trying to do breech birth well. And that is involving establishing a lot of relationships, trying to get a lot of respect from my colleagues and stuff that also attend breech birth, so that they know that the counselling that I give is robust, that my skills are robust. It's been doing things like buying the exorbitantly expensive Sophie and all of those sorts of things to kind of make sure that anytime that anyone questions my practice, that they can see that I have been going out of my way to be the best practitioner that I possibly can be, sort of thing in that regard. Watch this space. It's sort of still an unfolding sort of area. I do feel a lot of pressure to make sure that we have good outcomes as we're reintroducing vaginal breech birth back into a more standard sort of option for people. So like very much, wanting to make sure that we have good outcomes, because, just having one thing go wrong is absolutely just going to set us back decades.
Yeah, absolutely.
In the progress that we're making.
And I mean, like having the simulator, doing the training on a regular basis, all those things, that's what creates it within your scope of practice. And I think that can often get perceived differently by different practitioners, that breech isn't within our scope of practice, but actually anything within maternity, within reason, can be, as long as we are trained, competent, and keeping up to date with that. And that's really important for women and midwives and OBs to understand as well.
Absolutely. I know I've got signed agreements with 2 different hospitals in Sydney where breech is literally listed in my scope of practice. Like, it's on the list of midwifery skills, and you get to tick what, like, you can demonstrate what you're skilled in. And I'm like, yes, breech birth is in my scope of practice. Now, a cesarean birth is not in my scope of practice, and I'm never going to pretend that is not, it's not something I'm trained in. It's not something I want to be trained in. That is the role of the obstetrician. And to be able to deliver safe vaginal breech birth, we need to always have that engagement with our obstetric colleagues. But if that baby is coming out that woman's vagina, I am highly skilled and able to manage that scenario if needed, or to watch if also just needed. Yeah.
Yeah. So one of the questions I received from one of our listeners is, why would water not be an option with breech? Why do practitioners ask women to get out of water for their birth?
Yeah, this is an interesting one. So there are actually some midwifery colleagues in Europe that actually are really strong advocates of water for breech birth. And I'm at a point with one of my colleagues at the moment. We had someone recently who specifically wanted water in the end in her labour. She didn't get in at all. But we're kind of getting to the point where we're doing enough breech births where we're like, look, if someone specifically wants to birth in water, let's have this conversation. And historically, what I've sort of said to my clients is, like, if that's something that you really want to do, that's fine. But also, breech births are like a story that you're trying to read as the birth is unfolding, and you have to make very, very important decisions in real time. And if I can't visualize what the baby is doing, or if I think that the baby has better tone and reflexes than what they actually do because their body is floating in water, and I think that looks like a tummy crunch, but actually that's just the way the water is moving, that could influence my judgment, and it could influence it could mean a delay in me responding to something that is a situation that we would recommend intervention for. As we are building more and more of those breech births into our repertoire, we're becoming more okay with that. But I've also had a lot of clients go, look, if that's something that makes you feel more comfortable, they're quite happy to do that. And because I trained under Andrew Bissett's, he was a massive, massive advocate of the birth stool, and I've got my birth sling and my birth stool in my bag, and to be honest, it's my favourite combination, hands down, for breech birth any day. Yeah. And that's part of me learning breech birth from him as well.
So just for clarification for people listening, when they're on the birth stool, are you predominantly thinking of supine maneuvers if needed?
No, so I have one that we actually keep every 10, 15 minutes, get up, stomp around, do those sorts of things, and we change the direction. So sometimes we're looking at it as though someone is all fours, and other times we're looking at it from supine maneuvers.
Yeah, wow.
I guess it becomes that familiarity as well with maneuvers, is that you can see it and recognizing if you do have a posterior baby. One of the biggest issues with posterior and breech birth is people not recognizing that the baby is posterior because they're in a different position or something to what they're used to. Yeah. I mean, birth stools, particularly with supine maneuvers, like that front-on facing, it's actually a really good stepping stone from taking breech birth from being semi-recumbent to upright, while not having to overload that practitioner's brain with also having to rethink around what maneuvers
as well.
So they're able to, and then they recognize, wow, look, it goes so much better when people are upright, and then you can kind of go from there. It is a little bit harder to see tummy crunches. So I had one birth recently where, as I was watching back on the video, it was quite strange. The legs dropped down, and this is again making decisions in real time. It made it look like the baby was a lot flatter than what it was, and then as I watched back on the video, I was like, oh, there probably was a tummy crunch, but because I was looking at it from the baby's clavicles, it was only head flexion maneuvers sort of thing at the end, just to expedite that birth. That baby was followed by its placenta, which is, I'm sure, I think you've noticed. I think we had 2 last month that were babies, and then immediately their placentas. So situations where if there was a prolonged period of time where you're waiting for that head to be born, you could definitely have some poorer outcomes.
Another question from one of our listeners: what care options do women have in Australia if their baby is breeched?
There are actually options, and I think it is increasingly becoming aware that if your facility doesn't offer breech birth, that they are obligated to provide you to a place that will do breech birth. The hesitancy a lot of people have is, do I travel? And what if I end up having a Caesar anyway, and I don't want to travel all that far, and then end up with the one thing that I was trying to avoid? So then they kind of prefer to stay in their hometowns and those sorts of things. But I guess I'm I want people to be value having the people who are trained in this because we need more people demanding better to create this sort of change. You know, I've got a colleague in Perth. It's not a breech service per se, but there's a ECV clinic. You get like referrals to places that will do breech birth. Westmead Hospital in Sydney has a breech clinic. That's a publicly funded one. There will be engagement with private midwives in Sydney also privately, where you can have continuity of midwifery care in the hospital with breech births as well. And that's
great.
Yeah, exciting sort of thing moving forward.
Do you know of any in any other states? It's just those two.
Yeah, I don't know. We're moving slowly. We are. It can feel sometimes like you're pushing a boulder uphill, but we are making progress.
Yeah.
Yeah.
So women listening, start demanding it. That's what shifts things. We can only do so much as midwives. We need women, the consumers, to start saying this is something.
Absolutely. And I get people reaching out to me frequently. And, you know, 9 times out of 10, the people who reach out to me, they're not necessarily engaging me per se, but I am able to funnel them into the direction of getting the next best advice for their own situation as well.
Fantastic.
Yeah.
That's good. So, is a breech home birth an option for women in Australia?
The short answer is yes. And I have attended breech home births. I would also say that that is not the thing for everyone. And there are risks and benefits with everything that we do. And I certainly would not engage someone who was at 36 weeks deciding that all of a sudden, like, that is coming to for a breech birth and they go, and by the way, I want to do it at home. Like, it's a bit of a step too far in a short space, but it's a complicated one.
Yeah. And just like to elaborate on that, because women need to understand home birth is about developing trusting relationships, and having a late booking like that, it's not enough time to entrust us and trust you. It goes both ways. We need to have a full understanding of each other and what the other needs and what our boundaries are and all those sorts of things. So there is reason behind that. And so be able to support you in a hospital setting for those late bookings, because unfortunately a lot of women find out at that 36, 37 week, okay, baby's breech. So having more access to hospitals to support you in that setting is ideal, and more access to vaginal breech, of course.
Yeah. For me, I feel like someone has to already be planning a home birth.
Yeah. Absolutely.
For that to be a viable option. But also I would rather attend someone at home. I understand that there's a lot of people that choose free birth for a variety of different reasons. When it comes to breech birth, I would much rather be attending someone at home in a capacity that they are willing to have than for someone to feel like they're forced into birthing unassisted with a breech baby.
I would agree.
Yeah. Yeah.
Could you tell us, in the setting that you're working, what's the criteria? So you mentioned before about doing an ultrasound to check flexed head. Is there a criteria where you're working, what women should expect if they were to go into that setting with a breech baby? Yeah.
So look, we have done breech births with people where we kind of go, we know that baby's breech. We've had 2 clients where, you know, there were no ultrasounds, declining, you know, monitoring in labour, wanting pinards and those sorts of things. One of those allowed a fetal heart rate prior to baby being born, purely because of baby being breech, and recognising that there's a respect for women and their autonomy, but there also, I do think there needs to be a reflective respect for us as professionals and what we are putting on, particularly when it comes to breech birth. Like, there are some amazing clinicians that have trailblazed through this space of breech to allow us to be in the space that we're in now, but they often absolutely received a lot of professional backlash. You know, the way I kind of talk about it with my clients is, I'm not losing my registration for you and I'm not going to jail for you. There is no birth that is worth that for me. And if someone isn't interested in keeping me professionally safe, then I'm probably not the midwife for them in that sort of situation.
Yeah. Well, that comes back to that trust as well, trusting both.
That comes back to that trust, exactly. Yeah. But yeah, my experience, particularly even with Westmead's breech clinic, they are immensely respectful. Like, those criteria, they are doing breech in preterm babies. They are not, like, they're recommending. If there is a reason for an induction, they will induce breech babies. There is incredible scope. So I don't feel like the inclusion criteria are particularly restrictive or anything like that. And yeah, I don't know, I'm not really saying specifically what inclusion criteria are, but like, you know, big babies, small babies, amniotic fluid level. I mean, they're all grey, non-specific. Sometimes they're right, sometimes they're wrong. And we have to take that information on board. Like whenever I'm dealing with an ultrasound that says that a baby is big or a baby is small, it might be wrong. We know how inaccurate lots of things are, but it also might be right. My second twin was growth restricted. He stopped growing at 32 weeks and he was absolutely a growth restricted baby. And I made decisions that were in his best interest. They were probably good for me personally to make because they were decisions that I never thought as a midwife I would ever make. But they were also decisions that I made for his well-being.
You mentioned the induction. I hear so many stories when I talk to women about where they won't offer that. So it's an elective cesarean. That's all you've got. It's so good to hear that that is an option.
It is an option. That's probably a reflection of a service that is, in its early stages of offering a breech service. And I do think people have to be a little bit respectful of that. There is a service quite close to where I used to live that the manager there is absolutely fantastic. They have finally got VBAC off the ground. This is a hospital that didn't have VBAC until recently, and people would have to drive, an hour down to their referral hospital to be able to have a VBAC. They're now doing VBACs, and the very first person having a VBAC is like, I'm not having a cannula and I'm not having a CTG. Now, I completely understand the rationale why, that CTG is not going to save that baby's life and those sorts of things. But I can also see from a system point of view that they're trying to put into place and create progress. And then it comes down to that whole, if you do have a bad outcome,
you go backwards.
Yeah, you're going backwards. Yeah. So there are good people out there trying to make really good change. Yeah. But it's slow, so slow.
Very slow. Yeah. You've mentioned the Breech Clinic in Sydney a few times. Can a woman self-refer there, or does she have to be referred?
Absolutely.
She can. Okay.
Yep. So anyone can refer into both the Westmead one and the Breech Collective will be a self-referred model as well. Yeah.
How do they do that? Just in case there's anyone listening.
I'm just reaching out. So the Breech Collective has a website, through email there or through social media, those sorts of things. The process will be engaging, then initial consultations, offering ultrasounds. There will be ECVs offered if people would like to do those, all within those sort of standard sort of practices, and then counselling regarding their options, whether it is a caesarean section or a vaginal breech birth, and then, planning going forward in that.
I'll put a link to that website in your show notes as well. How do you best collaborate with the obstetricians when it comes to caring for a woman carrying a breech baby?
Look, there are some amazing obstetricians out there who are absolutely making inroads and making this more accessible for people. And I am a firm believer that long term we are going to make the best progress by working together and being honest with each other. So when I've had clients who have wanted to birth breech babies at home and stuff like that, and it can often just be people wanting to be really cagey. And I've always just said, I value the relationship I have with these obstetricians far too much, because professionally I need those relationships in a more ongoing sense than what any one person's birth sort of fits into that journey. So I'm never going to lie to any of my colleagues in that sort of situation. Having access to good neonatal resus is absolutely a fundamental part of being able to offer safe vaginal breech birth. Having access to timely caesarean sections for when we go, this is not working today, we need to do something different. That is part of safe access to vaginal breech birth. And that's what we saw in the term breech trial when there was poor outcomes, was those poor outcomes were the vast majority of the times with clinicians who were not trained in settings that were not prepared for those situations. So being able to communicate with an obstetrician and having that communication going both ways. When I have obstetricians know what my skill level is with breech birth, they're like, Ashlee can handle that. That's fine. But also if I'm not feeling like this labour is progressing the way I would like, I would really like to be in hospital instead of at home, because there are just enough red flags. And, sometimes that can be a reflection on our own previous experiences. I have seen some very big resusces after breech births, and that gives me a very healthy respect for it, because there are a lot of things that are outside of our control. Collaboration is the answer, always. I mean, from a clinician perspective, it's really important to document what we call transient injuries on a breech baby when they're born. I'll often take photos of things like swollen labia, testicles, bruising on the buttocks, those sorts of things. If you've got a complete breech with a foot that's dropped out for a period of time, that leg is going to be very, very bruised. And that's an important part of documentation from a breech birth, is having those sorts of things. The most common one is, regardless of whether a baby is born vaginally, the hip dysplasia risk and just standard ultrasounds for those sorts of things. We know that breech babies, regardless of whether they're born via cesarean or vaginally, tend to need more resuscitation and more help transitioning in life, depending on where you're at. It's not necessarily a experience that I have had. I know that the rates of nursery admissions in the first 24 hours of life are much higher than in their head down counterparts. So that's the main thing for people to be aware of. Yeah. Which is, totally worth. I mean, I never wish for someone to be separated from their baby in the immediate postpartum, but to have a good outcome in the short term, long term for mum, long term for that baby, for that mother's future fertility, for, some hours on CPAP, I do think that's worth it.
Yeah. Another question from a listener. Have you had any experience with fibromatosis coli or sternocleidomastoid tumour in breech newborns?
Not in breech newborns, no. And most of the time, I believe they're normally picked up afterwards.
Yes, yeah.
Yeah,
so it came from a listener who had that, and they were a bit shocked about finding it. And so it's one of her questions.
Yeah, no, I haven't ever. I think a lot of those things can be picked up like a few weeks afterwards as well. But no, I've never had that reported on afterwards. Yeah. I think they're also quite transient. My understanding is that they tend to resolve by themselves. So it's probably not going to be something that red flags. For us, we're kind of thinking about long-term consequences of not sort of much the transient things. So, I mean, it can certainly be a shock for people, but certainly not the most common sort of one either.
Yeah. Another question from a listener. Are you still likely to progress if baby's foot is presenting in front of their bottom?
Absolutely. This is where it comes back to people being familiar with breech birth and being able to define breech birth and breech nomenclature matters. Yeah. There are circumstances. So if I have a complete breech birth coming up, I will discuss how, if a foot drops out, how I would like to probably do. Like, I don't do a lot of routine vaginal exams in my practice. I'm a home birth midwife at heart, so I tend to be fairly hands-off. I do think it's appropriate to check that you have a presenting part following behind afterwards to understand where you are. Most of the time in your complete breech presentations, people are going to be, 9 centimeters dilated or complete at the time that happens. And as long as there's a presenting part following behind that, absolutely, we can continue, no problems. Whether to continue, if someone is 4 centimeters dilated and a foot drops through, it depends. Are we at home? Are we in the hospital? Is this someone's first baby? Are they likely progress? What is the woman's understanding of what the risks are there? Because it's hard. Like, yes, we look at some of the experience that clinicians have in developing countries where we get a lot of information that says that these babies will probably be fine. But also, what risk is that woman willing to take on there in this waiting? So, but also I'm aware of a lot of stories around Australia where a foot drops out and it's a complete breech, and it's just a complete breech drop foot, and they automatically get a cesarean. And I don't think that that's appropriate care. That's very different to a foot sticking out at 4 centimeters dilated.
Yeah.
And
I think unfortunately they're getting mislabeled as footling at a term.
Yeah.
And we know that's not the case.
Yeah, not the case. I mean, and that's the biggest red flag for any of us that are breech trained, is being told that your baby is a footling breech at term. That already just goes, okay. Well,
you don't understand.
Yeah.
I need a new provider.
Exactly. Yeah. If someone tells you have a footling breech, I'm actually aware of a set of twins recently where the presenting twin was footling. It was actually standing and curling around its second twin. But yeah, it's certainly not the thing.
Common.
That being said, second twins, completely different.
Yeah, of course.
Yeah.
They've suddenly got a lot of space.
Yeah, exactly. Yeah, they do funny things.
So just a question. You're doing a PhD, is that right?
I'm finishing up a research master's at the moment. So Hazel Keatle is my supervisor, and I have been looking at women's experience of uterine rupture planning a VBAC.
Fascinating.
So that's sort of where that's at. And as I get closer to submitting this thesis, I need to make a decision about what my PhD topic is.
Mm-hmm. Yeah.
I think some people in the breech world would like me to be doing it on starting a breech service. But my original plan was to do it on VBAC after multiple cesareans and abnormal scar incisions.
Yeah. I mean, which would still be helpful for those that are getting told have a cesarean because your baby's breech, like, because it's going to give further feedback on that. Yeah.
Exactly. I've got a breech birth coming up. It's a VBAC because of her first baby being breech. One of the obstetricians yesterday when I was talking to her about it, and she's like, it's such a shame that she didn't get the opportunity to have the breech birth first up, because now she's a VBAC breech. And it's like, even though they're two completely separate set of risks and we're happy to do it, it's just so unnecessary. And even when I look at my uterine rupture study, several of those women ended up on those cesarean pathways because of their baby being breech.
Yeah. And so that could have been avoided.
And so, a lot of Hazel's research around VBAC was, the cesareans happen and we need to support women to have VBACs. But then a lot of mine comes back to when that sort of more catastrophic outcome has happened. What started this in the first place? And actually being trained in vaginal breech birth is an important part of us reducing future morbidity.
Great. Can't wait to hear all about it in many, many years to come.
We'll see. It's taking me a while. Look, I do like the uni side of it. I do like the research side of it. It is a little bit hard sometimes juggling. I've got 3 kids. I've got a full-time caseload and study at the same time, but that's life.
Very busy. I appreciate you putting time aside for today.
That's fine. I mean, I'm always around breech stuff, always just keen for people to know what their options are.
That's great. So that's all I had. Would you be interested in sharing a little bit about your twin birth story?
Yeah. So, I mean, I'll start that my daughter was born in the birth centre at the tertiary hospital that I worked at the time. I had a very straightforward birth with her in that, I arrived about 30 minutes as a primate before she was born and I left 4 hours afterwards. So I was close to a home birth style birth as what you can get. My twins were born when my daughter was 18 months old. So, I was a midwife. I had previous vaginal birth. I am not having a cesarean unless, absolutely medically needed because I've got 18 months to look after, as if you need to recover from a cesarean with 3 young children to look after. I was lucky in that tertiary facility. Andrew Bizzet's around. I had another clinician that are very, very skilled in breech births. There was one conversation earlier on in the piece where they asked what I would do if the babies were both breech, which at the time doing a breech twin birth would be like
big deal.
Far more of, this is 10 years ago now, so a far more of a bigger deal than what it is sort of now. And I was like, yeah, I think I would. I had a few complications in that pregnancy that resulted in me being under maternal fetal medicine for one of my twins. And then by the time all that sort of stuff started resolving, my second twin was dropping off centiles. So I don't think I appreciated at the time just how inaccurate the scans could be. Like now I'd probably be a lot more wary about the information, and I'm not talking like small for gestational age, like less than 10 centile. I'm talking about abdominal circumference and everything being like first centile, estimated fetal weight, first centile, like proper growth restriction. But the clinicians were really good at being like, no, the benefit of them reaching term outweighs the risk of them a bit early, as long as you're aware of movements and everything's okay. I had a threatened prem labour admission at 32 weeks, which in the end was just me as a multip doing prodromal labour, which I continued to do from then in my pregnancy. Every single night I contracted at least 5 minutely from then till the end. And then it got to the point where, as a midwife, I never thought I would ever agree to being induced. I was nearly 42 weeks. I was 41 and 5 with my daughter. It doesn't help that you kind of get over it by the end of a twin pregnancy, but I knew I had a growth restricted baby on board. And so with DCDA twins, then you're looking at having a baby around 37 to 38 weeks. And with the growth restricted baby on board, I was quite happy to go with that. I was also less concerned with an induction as a multip than I think what I would have been as a primip. So I booked the induction for the day that the clinicians that I wanted who were going to be in charge in birth were on, because the person who was on the day before I had my twins, if that person had ever said to me, you need to go for a cesarean, I could have made a decision that was absolutely risking all my baby's well-being because I wouldn't have trusted them. But it comes down to that relationship and stuff with the clinicians who were on the day that I was in birth in at that day. Either of them had said, you need to go for a cesarean, I would have been like, let's go right now. Absolutely. The day before I had my twins, another twin mum that I was friends with, who had all previous normal vaginal births, her placenta presented after her first twin was born, and she ended up with a general anesthetic cesarean.
Yeah.
And so, it was a really good experience in terms of no one forced me into anything. I knew what was expected with standard twin birth. I knew that they would want me to have an epidural. I hadn't had an epidural with my daughter. I actually had a pretty big fear of epidurals due to a very severe and well-publicised adverse event that happened at a hospital that I worked at when I was a nursing student. And I had been involved in some care postnatally with that woman. So I never wanted anyone putting an epidural anywhere near me. But I knew that on that day that I needed to make the decision between prioritizing having a physiological twin birth or having a normal vaginal birth and being awake for the second twin if there was a reason. And having someone having that exact scenario of a placenta presenting in front of their second twin and being put under a general anesthetic the day before, it puts that into perspective. So I ended up agreeing to having the epidural on the day. They broke my waters for the induction. I was 8 centimeters dilated when I started the induction.
Wow.
So this was a fairly short process. I had been prodromal laboring for a period of time. And I remember turning to them and saying, you can bleep this out if you need to, if you guys want me to have the epidural, you need to do it now because this shit is not waiting for you.
They are coming.
I never got hooked up to the epidural infusion. I just had the single shot put in. I can't even remember if I even had a catheter put in. It was actually quite frustrating because I could feel everything, and the epidural only became effective as my first son was being born. So they're putting in, I'm waiting for it to be effective. I'm lying down, and I just remember sitting there thinking, how the hell does anyone choose to do labor lying down? Like, this is nuts. Everyone's finally getting everything sorted. They leave the room. And I'm just like, I can smell something. And I put my hand out, and it's I can feel a head between my legs starting to be there. So it was, a strange experience. I mean, on one hand, you have a staff member giving birth, so they're normally quite protective of things. But on the other hand, so my first twin was head down, by the way.
I picked that up when you said
on the other hand, you're doing. On the other hand, you're also having someone having vaginal twins, and we want to have as many people in the room for those sorts of things.
Mm.
I was an incredibly painful patient. They wouldn't let the pediatricians come in the room. I told them they could get stuff. There was enough people in there and that we'd let them know if we needed them. Typical midwife who knows exactly how to navigate what they want and what they don't want in that space. And one of the things, I guess, so after my first twin was born, my second twin was cephalic. And no, he was breech and tried to become cephalic, but presented with his feet next to his head into my cervix.
Fun.
The home birth midwife in me always questioned afterwards whether or not the maneuvers that followed would have been necessary if I had have been upright. But no one ever forced me into it. When people had asked me that morning what I wanted, it was just people standing around asking me, what are you doing? It was the most respectful care that you can possibly have. And I do think that having the active management of the second twin was in my second twin's best interests with his growth restriction. So I ended up having an ECV as well as an internal pedalic version. I had 2 incredibly experienced senior consultants in the room. And, my legs weren't even in front of me. They were like, you know what we need to do. And I can remember handing my first son over to my husband and really focusing on my breathing, going, I need to stay completely still right now, because if I don't, they can't do what is necessary and I will end up having a Caesar. And my second twin was being a little bit difficult in terms of his positioning. It was a little bit difficult for them to get a hold of his feet, which, you know, plenty of obstetricians will tell you that sometimes it's really easily, and then sometimes, particularly depending, like in the middle of the ECV, getting more into that transversey sort of position, it can be a little bit hard. But I can remember the look on the obstetrician's face when there was one point where she lost grip of his feet.
Mm-hmm.
And I think she was trying to be poker face.
Mm.
And I was just like, you know, I'm just staring directly at her and I was like, all right, this is it. But they kept going. They got hold of his feet. They pulled him down into a true footling breech position. I do have fun looking back at some of the photos from that birth because my second twin did not follow, even though they were kind of doing a love sets extraction-y type thing. He did not follow the mechanisms of a breech birth at all. My daughter was nearly 4 kilos. He was 2.1 kilos. So I pushed twice and he basically came flying out. So he was fine. I fed both of the babies. His formal blood sugar after that was 1.5 after a breastfeed. So he ended up in the nursery for just under 24 hours on a glucose drip. Again, I was a very painful mother advocate for my baby in the nursery, as you are.
Yeah.
Yeah, so I mean, it's not a breech story in terms of like a singleton breech or planned, but
you don't often hear stories about the internal pediatric version. That's quite rare that we hear about that now because often they just go right cesarean. So it is great for women to be able to hear that that is a thing. It's not something you necessarily want without an epidural. However, I have seen that done. Christine has done that for a triplet birth, and you've got to remember everything has been opened. There is space. Yeah.
Everything is open. There is space. And one of the things, so 2 of my midwifery colleagues that were part of my group practice, I'd shared care with them. So like I had my closest friends and colleagues with me. One of the things that she turned around to me and said afterwards, she goes, you knew that was going to happen, didn't you? And like, I think there was some level of gut intuition that even though I hated the idea of having an epidural, that pointed me towards the idea of that was the right decision to make on that day. And I've always questioned, would I have needed the internal pedalic version? But maybe I would have. Like I could have been upright and he still tried to do the half swap from breech to cephalic and failed miserably at it. And at least my epidural was becoming effective. It wasn't fully effective, but was becoming effective as they were doing that. And because the chances of that, like as you can see in the video with Christine, like if you are tense, you are making that job so much harder for them. So that is so important for that woman to be fully informed and engaged in what it is that you're trying to do at that point. So yeah, like I have had the experience of an internal pedalic version. I have had the experience of a breech baby, and considering the counselling and stuff like that on both sides of things, attending lots of breech births, never in that first half of my career would ever have thought that I was actually going to experience any of that myself.
I just want to add on here for anyone that's interested in what we're talking about in regards to Christine doing that internal version. Obviously, you can't see what's going on inside, but on her Instagram, Global Midwife, there is a beautiful birth video of a triplet birth, and it does show that she does go in. So if anyone's wanting to watch that.
Yeah, which is an appropriate management thing. I think that one happened because the placenta started abrupting after the first 2 were out. And it's essentially when we're talking with twin women about having twins without an epidural on board and why the hospital wants to have it, it's around there are some maneuvers that are maybe less likely to be successful if you don't have analgesia on board. And we're more than happy to, like, the obstetricians that I work with, they're like, they don't have to have an epidural. We can do those things without. But it's how would those women feel, like they need to know. They need to know what is involved in that, and it's a significant internal maneuver.
Yeah, absolutely.
Yeah,
I've tried it with the simulator, and it's tricky on a simulator. I can imagine how tricky it would be on a real person, real humans.
When I was doing internal version simulation with Stu, when he was out, he goes, have you done this before? And I was like, not explicitly on another person, but I remember what it feels like.
Yeah. Amazing. Any last words of wisdom or advice that you'd like to offer any women listening who have a breech or twin babies on?
Get informed, know what your options are, reach out to people who can help you navigate it. And we need more people demanding better of the system. Yes, the counselling around vaginal breech birth can be a little bit scary at times. It really shouldn't be, but we're just trying to make sure people are aware of where that history comes from. You know, there was a period of time where I thought breech birth was fine so long as you had skilled care providers at it. That it's not a guarantee that something bad isn't going to happen, but that happens in cesareans and any birth at any time anyway. What matters most is that you don't have something going bad because someone's doing something stupid. And that's...
Don't know what to do.
Yeah. I don't know what to do, don't know how to respond to the situation, and know that there are those of us out there that are spending hours and hours and hours trying to be the best practitioners that we possibly can be so that we can make this as safe as it possibly can be for people.
Perfect. Thank you so much for joining me and
No
sharing your
worries.
story. It was lovely to connect and speak with you.
Right.
The Breech Birth podcast is independently created and produced. If you'd like to support the continuation of this space, you can do so through Buy Me a Coffee. Your support helps keep these stories being shared and accessible to women and families around the world, and you can find the link in the show notes. Thank you for listening to the Breech Birth podcast. These stories matter. They stretch what we think we know and bring voice to experiences that need to be heard. I'm so grateful to our guests who have shared their experiences with us, raw, real, and full of wisdom. If this episode resonated with you, please subscribe and share with others. You can find us on Instagram, Facebook, and YouTube at Breech Birth Podcast. And if you have a breech story to share, I'd love to hear from you. Until next time, may we continue to reclaim the narrative one story at a time.